Well, first of all, thank you for that really overly generous introduction. Having had a weight problem, being called a giant psychiatrist, and I'm trying to be a diminutive, more of a, let's say, less of a giant, but thank you. Very kind words. I would also like to say, obviously, thank you very much to Igor and the committee for the chance to be the first presenter in this annual series. And the really nice thing about being the first presenter is I can actually fail and the next guy will look really good. So I'm excited about it. The third thing is that it's a little bit like old homely, because I know so many people here have had relationships back and forth with UCSD for some years. It's just very nice to see. I wouldn't say old, but not seeing it. So thank you for having me back. It's been a great time to meet the students, and I'll be more with them this afternoon. Also the medical students and the residents and so on. So it's been a lot of fun. Thank you very, very much for having me. This presentation is not research. This is more of a reflection of my thinking and concern and perspective, having been in Singapore for 5 years, really outside of the U.S. culture. Though I have to tell you, everything that you do in the U.S. is worldwide famous. So when Dr. Kupfer and Dr. Ginsel have a fight, everybody in Singapore knows about it. There are some things we should be a little more circumspect about as opposed to broadcasting, but that's an aside. And I'll tell you what this heuristic and algorithmic stuff is, but because I was in Singapore and I lived in a culture that's quite different than ours, with a whole different set of circumstances, in a medical school that Ranga Krishnan was the second dean of, but he was really the first really on-site full-time dean. And it was a graduate medical school modeled after Duke in the U.S., so it was undergraduate requirement. The other medical school there is British. So it's a community college and then 6 years the housemanship process, which is famous in England and really worldwide. It got me to think about, my job was as Vice Dean of Clinical Sciences, how to introduce research as a career track for clinicians, not just psychiatrists, but also for internists, surgeons, anesthesiologists, etc. How do you do that in a very, very, very busy healthcare system? How busy is it? 6 minutes per patient in the atrial fibrillation clinic as compared to 20 minutes per patient in the Duke USA atrial fibrillation clinic. So you can imagine that this is a very tough place to work. And by the way, if you don't make your quota, your salary gets cut 20%. So it has carrots and sticks built into the process. Meanwhile, of course, my job is to persuade these fellows to do less clinical work, maybe make less money and love research. You start to see why it has some application in our current situation. The other thing I want to say is that I will speak about academic medical centers in general. I'm going to give you some opinions, I'll give you some data, but I want you to, as we say in psychotherapy, not take it personally. It has nothing to do with UCSD, okay? It is a general set of remarks, largely based on my experience at UT Southwestern, but I think that in general, this is lots of changes are happening, and we're having to confront some revisions in how we do things. So please take this as sort of a set of opinions informed by some work that I'll tell you about. Okay. So with that, here are my disclosures for the last couple of years. I currently am employed without a W-2. So I live in Santa Fe and I do intermittent consulting and visiting. And I also get up in the morning and say, gee, I wonder what I want to do today. And that's not a bad thing, by the way. Okay. However, I must say, Santa Fe is not a place you want to move to if you want to have things happen fast. That doesn't happen. And a straight line was an anathema to artists, so that doesn't happen. All right, so let's take a look, overview of the academic medical center. And then I'm going to drill down and explain what algorithmic and heuristic is. And then I'm going to talk about how that may lead us to think about what we do in a different way at the academic medical center. maybe provoke some conversation, discussion, etc. In the Q&A period. Okay, so ultimately the name of the game is we're improving the lives of our patients. And we do it at the Academic Medical Center, of course, by our three major pillars: research for future, direct clinical care more in the here and now, and of course teaching the next generation. So that is what we're used to, and our problem has been in the old days, some of us were raised believing that we could be the so-called triple threat. We could do all three things: walk, chew gum, and mail letters at the same time. Okay? And that was easy when clinical care was more casual, when research was a lot easier to get, and you didn't have a bureaucracy of educational requirements and boxes and so on. I'll come back to that. Now, however, we're being asked to do some things that, on the face of it, actually turn out to be a conflict of interest. In the following sense, we're asked to educate more students, use the processes we use, and do it faster with more people. At the same time, we're supposed to innovate and do things differently. So innovation, heuristic, and process, factory production, algorithmic, I'll come back to that, are the kind of the meanings of the words. The same for patients. See more patients, but innovate care. In a certain sense, we're saying follow the guidelines, but write new guidelines at the same time. It's an internal conflict. And of course, some of us really like this. That's why we went into academic medicine. It's not a bad thing, it's a good thing. But it's hard when you're trying to drive both behaviors. And the same with research. We always like more money. Now we love intellectual property. But of course, we're also supposed to be innovative. And oh, by the way, don't forget to educate the next generation and tell them how to get these grants, which are becoming more and more difficult to get. Okay. Oops. So the question is, how do you meet the challenge? There are a number of forces about that are forcing us to rethink what we do in academic medical centers. And this is certainly true in Singapore as well as worldwide, probably. One is our Affordable Care Act. What is the role of the medical system in a school in the delivery of care to a population? And how can we do that in a more efficient manner? Global competition is very, very key. Lilly, the company, has reduced research spending in the U.S. by 60% over the last decade. That's a serious loss of revenue opportunities for those of us that do research. And they go somewhere else. It isn't like it just disappears. I can tell you where it goes. I was over there. So they try to make relation to commercial opportunities and monies very, very easy in Asia. We'll come back to that. We, of course, have the federal budget issues that I won't regale you with because we live with them all the time. But when we're unable to make strategic decisions about where we invest and how we manage our budgets, and we go instead to sequestration, we have a problem because everybody, there's a selective cutting and research is taking a huge hit, as you all know very well. I would also suggest that we have prolonged our training periods to too long. I think that we need to cut medical school training by a year and residency by a year. And I think that, I'll give you an example of the mean length of time to get a PhD in physics in 1953 was 3 years. Today it's 10. I can't believe that our physicists are 3 times as stupid as they were in 53. It doesn't make any sense. And I think we have to be realistic about this because if in fact all of the physicists that were in Los Alamos were under age 30. You can't get a PhD until you're age 35. It's very hard to be innovative, especially with physics and math. A lot of your creativity is very limited. And the advantage of having young people enter the field at a level where they have some influence really sooner rather than later taps their creativity because they will come having not been inculcated in with all of the silliness that their elders have already inflicted on them. I think that's very important. The academic commercial silos I've already alluded to. While there have been obviously transgressions and egregious behaviors by some researchers and certainly some companies, to throw out the baby with the bathwater is not the smartest thing in the world in my view. And we have made relationships with industry, I think, perhaps too arduous and gotten in the way of what really can be valuable support. An example, which happened to come out yesterday when I was talking to psychology students, is the only study of chronic depression in which medication, psychotherapy, and the combination were used was entirely supported by Bristol Myers Squibb and published in the New England Journal of Medicine, despite Bob Crine having had 3 workshops on getting the study off the ground to find out when combination treatment was clearly indicated, because the psychologist said never, the psychiatrist said always. And it was really up to NIH to do it. NIH never got that off the ground, but that particular study, very well done, not inexpensive, but rather definitive, and narrow sort of chronic depression. So there are opportunities there we, I think, are casting away. And academic discipline silos, what I mean by that is, and this comes from my work with the CTSA in Dallas and then the development of the Academic Medical Research Institute over in Singapore. What we have found is when you put the anesthesiologists, the surgeons, the psychiatrists, the internists, the endocrinologists, the emergency room doctors, the neurologists together, and you have a discussion about research and proposals and ideas and how do you solve this problem and so on, it's amazing what psychiatry can learn from cardiology, and by the way, vice versa. Because they're dealing with problems like we deal with, but we don't have conversations with them very often. So we have created silos that may not be in our best interest for the most impactful and useful research. Okay. Other forces forcing a rethink about academic medical centers. AMCs have become a business. Sometimes that gets in the way of our actual generating knowledge and training students. And in my view, at least from the Singapore perspective, and I think a little bit in the US, there's jobs dissatisfaction is higher now in academic medical centers than 5 to 7 to 10 years ago. I may be wrong about UCSD, but I don't think I'm wrong in general. And the incentives are more assembly line or production oriented, and as some people would say, I didn't go to medical school to white chickens on an assembly line. I'm more thoughtful than that. Not that we don't have production that we are capable of, we need to do. And budget realignments have to do with, in the old days, we used, of course, we would work half-time and live on the clinical revenue the other half-time until we got a research grant and so we could allocate our time very readily. Now, of course, everything is very tight, so you can't just live on the clinical revenue, you can't just live on the research stipends and so on. Okay. This is a quote from the Senior Medical Director of Pfizer. I saw a lecture, people don't change, let me see the light, people change feel the heat. And my sense is we are now all feeling the heat. So I don't think we have a choice about change. The issue is how do we make the change in ways that will be good for us and good for our patients. So I want to tell you about this book I read, and please, if you haven't read this book, you need to read the book. I'm going to just summarize a little bit because it's where I got the algorithmic heuristic notion words from. So it's an easy book to remember. It's a book called Drive by a guy named Pink. Okay. So this is very interesting. So it's a little bit of an aside, but you'll see it'll come back to kind of what are we doing in our work. So the notion in this book, put forward by Pink, is around 1947 we recognized 2 kinds of drives, biological drives and extrinsic drives, rewards and punishment. There was a gradual evolution of a recognition of so-called intrinsic motivation, which I'll tell you about in the next 2 slides, initially by Harry Harlow. What Harlow did is he had these devices he was going to put in the monkeys' cages, and he wanted to know about how he could teach the monkey to solve the problem. Solve the problem is opening a latch. So he put these things in the monkeys' cages, getting them used to it, and then he was going to deprive them of food or water and get them motivated to solve the problem. Okay? The problem is they solved the problem without any desperation of food or water. What screwed up his entire life. He went into a whole other area like how monkeys relate to each other, and he gave up on this, but subsequently this became a whole study in occupational psychology. And lo and behold, if you think about it for a minute, Angry Birds is the primate solving the problem. Who would have known? You have a completely useless game selling billions of people, right? And what do? They'd rather play the game than eat or drink. I don't know about sex, but that's another story. Okay. So the notion is there's this intrinsic third drive or motivation. That leads him to conceptualize work in what he calls work 2.0, algorithmic, and work 3.0, heuristic. Algorithmic being rather standardized, routine, extrinsically motivated, somewhat repetitious, but we have to do a lot of that, what we do. Okay? And it gets very automatic, like driving your car, you don't even think about it. Right? Heuristic being quite different. You actually are presented a problem, and it's a problem which you have to actually solve. There are no guidelines, there are no algorithms. And so the definition of heuristic, meaning having to organize information and reconceptualize what you're thinking about, how you address the problem, arbitration, bridge playing, and so on. What about, and now I'm going to make some analogies. So established instructions, that be practice guidelines, single path, is that treatment algorithms? Take drug 1, use it for 3 weeks, if it doesn't work, turn around to drug 2, da-da-da-da-da. Okay. A single outcome, usually directed by others, and not very challenging. In fact, not very much fun. Okay. An aside. So I'm talking to the psychologist yesterday about cognitive therapy, and I explained to them that the book on cognitive therapy was meant to be illustrative of things you might create when you see the patient. And they're just examples. Instead, what we have created is a checklist for did you do NP therapy, how long did you do it? Did you do triple column, how long did you do it? Did you do quadruple column? Did you do a mood graph? Did you do graded task assignment? And when we wrote the book, we had no illusion, we not a thought that it would be a workbook or a recipe. It was to help people develop a heuristic about how the patient might change their mind with their attitudes. That, I think, is analogous to the problem that we have now in practicing medicine. Having been involved with guidelines in '93, I am now talking about guidelines misconstrued or misused. And it's a very, very serious problem. And I believe that it is actually produces worst outcome, which is what Pink talked about in his book, but he doesn't know anything about guidelines. Okay. Heuristic work. We don't know what we're doing. We actually got to figure out what the heck is going on. Okay. So novel solutions, not rule bound. You got to play around with possibilities, and it's trial and error. Okay. Trial and error is when you run out of guidelines and should you use Paxil to treat resistant depression. Answer: I don't know. We got a little study here and a data there. Which kind of patients? We don't really know. All right, we'll give it a shot. What does give it a shot mean? We're going to give it a try. How long? How long? Well, it's Roy Perlis' study or somebody else's study. Let's go 4 to 8 weeks. What should we see? Oh, we got to measure outcome. We don't just say, how you doing? And you don't say, oh, you went to Las Vegas and gambled away a lot of stuff because we must have a total system. We want to look at bad outcome, good outcome, and it's trial and error. And we say, the person who doesn't work, don't worry, I have another arrow in my quiver. And we are now doing heuristic work. What's interesting is some of us old people, every case we saw was with a, quote, supervisor who helped us understand the heuristic that we needed to create before we got the guidelines. Okay. So, allowing for failure, and this is the most important slide in the entire line, because this is the summary of Pink's book. To drive algorithmic work productivity, carrots and sticks or extrinsic incentives work. So if you're hanging a door on a car, and I tell you you're doing 5 doors an hour, if you do 7, I'm going to give you 2 sevens more of your salary. They actually increase the productivity, and the quality doesn't usually go down, but you got to check. If you, in fact, ask someone to do more problem solving in a time limited fashion, don't see just 3 patients per hour, see 6 patients per hour, and do a diagnostic formulation, a treatment plan, and implement it. What you have, if it's not algorithmic, if you really haven't got the story straight, you will make more mistakes because your focus is much more narrow. You can't play around long enough. What about this? What about that? And you ask some additional questions that lead you to, oh, it's the other medication they're taking rather than something that happened in their life that's causing depression. I'm going to change the rates out or whatever. Okay. And in fact, he lays out in several chapters in the book, that's why I really encourage you to read this, that in fact, when you use carrots and sticks or extrinsic incentives for heuristic work, you actually change intrinsic motivation into direction. it's kind of, and it even shows this with a number of experiments that have been done, including in Sweden, where they want to increase the blood donations, so they offered money for blood, and the number of blood donations went down. Okay? Because what happens, people volunteer, and they say to their mother or father, you know, I gave blood, it was very important, blah, 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 victims of Red Cross. So it's now become a business. And it's a business in a negative sense, meaning the drive is gone. Can actually diminish performance, your ability to solve problems, which require sort of lateral thinking is impaired. It crushes creativity, and I won't go into all these, but each of these are supported by lots and lots of evidence. Okay? Become addictive is, well, you gave me $2 per door last year, but now I need a raise, but I'm not making any more doors. Okay? So I just need a raise in other ways, but my productivity is not going in. Okay? And the other problem is, of course, it's very short term. So everybody's convinced of this, right? Okay. What about our medical work? Well, there is stuff that we do that's algorithmic, of course. I mean, better be. We shouldn't have to do a new, you know, every patient's different. I mean, my God, some of them need to know how to solve problems, and there are general rules. So, by the signs, getting lab tests, reporting the current medication, monitoring outcome when somebody is stable, sure, that's more routine or algorithmic, but diagnostic reformulation, treatment planning, treatment initiation, revising the treatments, all of that requires a rethink of what we're doing. And it's important, I think, to do that because otherwise we are not serving our patients well. This line struck me much in the book, which is partly because work has become more creative and less routine, it's become more enjoyable, and I thought, that didn't sound like Singapore. It was like more work, not so enjoyable, go to private practice. And that was the struggle that they had in the public sector because the production was largely incentivized by sort of algorithmic skills. So my thesis is this. Inappropriate use of extrinsic incentives saps innovation, productivity, messes up job satisfaction, and actually may produce poor practitioners or worse outcomes. And what we need to do is revise how we do things in ways that recognize the need for algorithmic work, but also allocate the time and effort for heuristic work, and we have to innovate our way out of the problem. So I'm going to take you through a little bit of what I would suggest, and these are just off-the-wall suggestions that may start a conversation or a debate or an argument. I certainly don't have all the answers to this. I do think this is a time where things are changing a lot, and it's very good for us to put in our thinking cap and come up with some new heuristics for how we play our game and what we do. So, what happened to medical heuristics? Because it sort of disappeared, like, you know, see the patient, punch the clock, and get them out. I think evidence-based medicine has been oversold, extremely so. And the reason I say that is because I've had to look at the literature, and then I had to look at the patients. And a lot of the patients I see are not in the literature. Simple example we did from Stardy, it's very well in the day. We looked at how many of our 2,800 patients that entered Stardy would have been acceptable in a phase 3 randomized trial run by the FDA. And the starting answer is 650. Wait a minute, 650, 28, oh dear. Gee, that means more than 3 times out of every 4, when you're practicing medicine, you're giving an antidepressant to a patient who's never had the drug in any phase 3 trial. And what do you find out? You find out when they have a whole lot of general medical problems. Their outcomes are not very good. When they have a lot of anxiety, medical morbid disorders, their outcomes are not very good. The real question is, are their outcomes any better than placebo? There was no placebo in the study, but the outcomes are not good. As in 35%, 25%, 15% response, just at level 1 and 2. So that really raises the question, should we be treating people who have cancer and depression or have 3 anxiety disorders and depression with drugs at all? We don't have any randomized control trials to answer the question, but we need to be circumspect about how certain we are. Okay. And that is not just true in depression, and it's not just true in psychiatry. If you talk to the cardiologist, they'll tell you exactly the same thing. And there's a reason for it, which is those trials are designed to have high internal and very minimal external validity. Okay? And then there's a lot of, then you get the drug on the market, but we have lots of, and I'll talk about the questions that are left when they come on the market, but they're all really critical key questions, which is why the guidelines don't always work, or at least we don't know if they're applicable. The other thing is practice guidelines, again, have sort of become the distortion of cognitive therapy of depression book. supposed to, you actually use it like a recipe. No, they're called guidelines. I'm like, think about this, but you got some latitude, a little bit of confidence, or maybe lack of confidence in it. So don't take these things too seriously. Okay? The problem is that the care delivery system takes them extremely seriously. Oh, we don't have any guidance on that, but you can't do it. Oh, great. Well, we're not going to treat about half the people we see because we have no evidence. And that's what I mean by overselling evidence-based medicine. It has become an industry without a scientific base, in my view. And then it's become a political, administrative, and economic hatchet. Care reimbursement systems? Oh, they love this because these guys are trained from Wharton Business School to get guys to pluck chickens on assembly lines, but they haven't got a clue as to what we actually do in the clinic when we do our heuristic work. And that's our fault. We should make what we do more transparent and more clear to those that help us manage our systems. We also have become preoccupied with documentation. If there's a box, you got to check it. You can never have too many boxes. And eventually, I really think the Saturday Night Live visit with the physician will be, the physician gives the patients the papers and said, you fill out your paperwork, I'll fill out mine. See you next week. At some point we go, what is the return on investment? And I want to come back to that because I really think this is a chance for leadership, not at just the department or the med school level, but also leadership right in the clinic. The people that know how to solve these problems are clinicians and patients. I think that we have to start listening to, not Prozac, but the patients and our doctors. Okay. And finally, the heuristic work is neither documented nor reimbursed, and that, of course, is very, very difficult and supported. What are the effects on medical care and education? I'll talk a little more about this at 5:30 faculty club, but just a little bit of a highlight. So I think the quality of care is now being rated by guideline adherence. Not the best thing in the world, and the guidelines don't apply for half the patients we see anyway. We are teaching guidelines without teaching the heuristics. Very dangerous. You know, this is what you do. Don't ask me why you do it. Not a good idea. Because you got to think through. If you're doing it for this reason, it doesn't apply to this person. I'll give you an example from my own management of my atrial fibrillation just 2 weeks ago, because there were new guidelines out to tell us that people over 70 don't really need to have blood pressure as tightly controlled as people that are younger, right? Whose genius was this? Okay. First of all, remember some people live to age 75 and some to 100. I want to know how many people live beyond 85 in the study, with the study. But so my internist said, my family doctor says, well, you know, we don't really need to jack your medicine up, blah, 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 and so it's a pure falling over, blah, blah, blah. So my hypertension was fine. It's been 120 over 80, but I had to change the drug because I had some reaction to it after a bunch of years. So he's trying to convince me to go to the 150 over 100 or some wacky number. So I go over to the cardiologist and I say, look, I think that this internist is nuts. He's got these guidelines and it's my heart. So, and the internist said, well, let me look at sonogram and do you need anticoagulant, da-da-da-da-da. Okay, so we worked all that out, and the cardiologist, who's also 71, like I am, says, no, you know, I think you need to get your blood pressure, quote, as low as possible. The other guy's going, I'll take 150 over. So I said, why do you think it should go as low as possible? Because he said, you have atrial fibrillation, you have slight left ventricular hypertrophy, and now you have small mitral valve regurgitation into the atrium, but your ejection fraction is 60%. Sorry if some of you don't follow all that, but he's giving me the physics and the heuristic of why he's telling me to get my blood pressure, you know, reasonably low, 100 over 60, 110 over 50, something like that. And I've had it like that before, and I don't get dizzy, and I don't get orthostatic, and so on. So I go back to my internist who loves these guidelines. He feels so good with those guidelines, and I feel so bad with those guidelines. And I'm going, oh, he's going to kill me. And so I said, no, remember, blah, 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 this and that, and da, da, da. Oh, yeah, well, I haven't read the thing from the cardiologist. So I said, please read it. So he's reading it. And he's looking for a reason to kind of placate me, because he can tell I'm not happy. I'll change internists before I fool around with them, right? And he reads this and he says, oh, yeah, you have a little mitral regurgitation. Okay, that means you need to have your blood pressure lower. What he did was he said the evidence doesn't apply to you. Okay? People in this group were not atrial fibrillars, and they didn't have mitral regurgitation. They weren't me. P-I-C-O, population. So that he wouldn't change the I until he changed the P. Okay, that's EBM talk. Okay. So I think it's very important that we really teach the heuristics, because the heuristics give us, as clinicians and researchers, a great understanding of what we're doing, why we're doing something, so we can decide to not do it. In the depression guidelines in '93, it says these guidelines will not apply to everyone. You need to be very clear about whether or not this is appropriate for your patients, and this is general guidance based on group data. We are dealing with the idiographic nomothetic problem, individual versus group. Okay. All right, so you've heard me on that before. I'll try to move through this a little more. But the other is, I think, that we're kind of pursuing the art of medicine, which is seen as fuzzy by people because we don't have all the evidence. Right? We should never have all the evidence. And then the administrators get in, and why don't we hassle people if they don't follow the guidelines? In fact, we'll cut you off from the pharmacy, you have to do this or that. So there's a better way to practice medicine than we're now doing, and I think there's a better way to educate. The reason I came up with all this is I was in Singapore and I had several epiphanies. I'll give them to you very briefly. Imagine filing your income tax once a year, 3 questions, on the web, done, less than 5 minutes. That's how you do it. It's all done. You don't need an accountant. In fact, you don't even pay it until it's due. Amazing. Imagine that you're not short of organs or an organ donation because you're in unless you opt out for religious reasons. So everybody's an organ donor except that it's against your religion. Imagine going to a movie and having a seat already booked, so you don't have to get there early in order to sit in this seat or that seat or the other seat. And imagine a healthcare system where everybody has healthcare with 3 levels of no subsidy, some subsidy, big subsidy. Everybody gets very basic care, but not everybody gets all possible care. Dialysis beyond a certain age, not available unless you pay for it. Lung cancer drugs that won't extend your life more than 6 months, not available unless you pay for it. So there's a balancing act, which means everybody gets something, but not everybody gets it. And you can call them death panels, but I think it's a realistic allocation of resources. You don't have all the resources in the world. You have to be smart about how you use them. And there was a great article yesterday in the Wall Street Journal. I don't know if you saw it, but it was the Powerball lottery method in allocating NIH grants. Use the evidence. It was serious. 2 serious guys, one from WashU and the other guy from Einstein. Immunology, microbiology, real serious scientists with real things. And they said, look, the review committees can't tell the good guys from the good guys. And so they're trying to get, 1.2 has to become a 1.1 in order to get funded and waste a lot of time changing something. And why don't you just have them decide good science, not good science? But now you've got 40% of your grants, which would be good science. Take out a dark word, throw a dark. Right, because you cannot actually predict differential outcome based on the 1.2, 1.4. And it's not illogical because there's $120 million going into grant review, and the grant review can be done very quickly, and your grant stays in the lottery, so that you have a new draw the next time and a new draw the next time, but you can pull that grant out and put another one in if you think it's better, as long as it goes back through and it's called good science. The reason that that's important is we have a limited number of resources, so we have to be smart about our resources. I don't think that's a crazy idea unless we change the resource allocation. Okay, so what are the new heuristics in these areas? I'm going to be real quick about this, but hopefully provoke some discussion. Educational objectives very clear as professionals, and also I would underline that we need to provide education to families and patients as an academic medical center. And I cite Johns Hopkins as a very great source of information, whether it's on dementia, depression, or prostate disease, whatever that. So we need to do that. Everybody knows that. And I do think that we need to shorten the training time. I don't think that's a crazy idea, and I think it can be done. I actually think in psychiatry that there's 1, 2, 3, 4, or 4th year you can become a child psychiatrist, but you're already qualified as an adult psychiatrist. That proves you can finish adult psychiatry in 3 years. Good, if you want to be an adult psychiatrist, why hang around for another year? Go into practice, not bad. I believe you can shorten medical school. Why? Because Duke doesn't. Year 1 is basic science, year 2 is clinical, year 3 is research, year 4 is clinical. They do pretty well. So what they've done is taken a year out of med school and called it research. And literally there's almost nothing there except a brief family medicine. So you do med school in 3 years, you do psychiatry in 3 years. You're now 6 years out of college and you can go into practice, or you can take a fellowship, or you can do further research, or get a PhD. And now you've got more time to actually get the PhD. Don't start me on the PhD. Okay. Educational needs. We need to educate broader groups, and enhance professionalism, and so on and so forth, as you can see here. How do we, so how do we do that? I'm going to talk about this more at 5:30 today. But what we did is we replaced all the lectures with seminars. And the lectures are all on a memory stick, and so that the young people listen to the lectures when they're rested, they feel okay. We give them almost everything they need to know on the first day they show up, including the answers and the questions, and so on and so forth. And we're starting in this mode, but I don't think we've done this yet. I'll talk a little more about this at 5:30. So these are some educational innovations, and I want to just underline use measurement-based care. Measurement-based care is, it sounds like it's new, but it's like, that's how you do medicine. I mean, how do you know your blood pressure is better? You measure it. It's not exactly innovative. But unfortunately in psychiatry, we don't seem to be too keen on that yet, and I have no idea how you know if a person's in remission other than you say, how you doing? And that's not going to be as precise as it should be. So our practice here, I'll talk about it at 5:30. Research, okay. So we have 3 kinds of research. This is the translational, everybody understands what that is. This is clinical, these are the sorts of things that we need to do to accomplish clinical research, and these are health services. All right, so they all relate together, and those are nice things. The problem is, there are a lot of threats to academic research, which I don't have to tell this department about because it's a highly reviewed research department. Constantly searching for yourself makes life extremely difficult. I don't have to underline that. So you pray for a K award, the K awards are being cut back. Limited access to commercial dollars, unpredictable budgets. I will underline non-U.S. career opportunities. Believe me, I've seen people being brought from Mount Sinai, 5 years contract, work in Biopolis in Singapore, very happy to never go back. They become permanent residents, they keep scientists working. And of course, we have lots of bureaucratic burdens. As things get tighter, there's a tendency to direct research. We'll only fund this, we won't fund that, I know a good idea, I don't know a good idea, and the committees get narrow, the entire bureaucracy gets a little bit more narrow. And at least at some med schools, the demand for intellectual property, the prolonged training periods, the academic silos, and the difficulty in promotion and tenure and recognizing patient-oriented researchers and their collaborators as true academics is another problem. An example at Stanford, you have the tenure track for the guys that discover how nature has changed, or changes, or works, but for the patient-oriented people, they're on a clinical track. And so it's a differential that may not be the best way to go forward. And we already talked about the commercial isolation. So what do we got to do? Of course, we have to do the usual: cut costs, increase efficiency, enhance cross-discipline collaboration, and lower our operational burdens. And I believe that last one is actually fairly easy to accomplish if we have the right kinds of incentives in place. And the cross-discipline collaboration happens informally. I would just think you could make it much more formal. Clarifying career paths is extremely important. Because what is the career path for a patient-oriented researcher, not a PhD lab-based researcher? And how is that recognizable? And of course, expanding the time for university fellowship. So here's some suggestions. Hold cross-departmental or cross-disciplinary research seminars. We did that at the CTSA in Dallas. It worked extremely well. Create stakeholder advisory boards, not just as PCORI did or old mental health clinical research centers, but as a department. Maybe consider some stakeholders that will include patients, families, scientists, and so on. Link academic centers together for rare diseases. Create registries. I'll talk a little more on that. And revise the promotion tenure process a little bit. Simple things. The consent for STAR-D was 24 pages, single-spaced. We had to actually, I'm not making this up, it's almost hard to believe. Harry was there. And we had to go through every possible drug in the 20, 15, I don't know, 12 drugs we had them go through. And they just started at level 1, we had to reconsent them into level 2, level 3, level 4, or follow-up. Okay. They actually had to read all the side effects of all the drugs they might actually get in order for them to understand what they're getting into, knowing that most of them will never get to level 4. In fact, most didn't get to level 3. And then we reconsent them anyway. And that is simply overkill and silly. I believe that the essence of informed consent is to be informed. I believe you can do that in 1 and max 2 pages with bullets. What's the study? What's the risk? What's the downside? Can you get out? Can your doctor pull you out? What happens if we damage? Those are like the 5 questions, 6 questions. The rest is more details, which you can put in the back because the lawyers want to be sure, well, if this happens, it's that, and blah, 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 blah. The patient can't follow that. So they're really uninformed. So we can just simply make this very, very simple. Simplify research outcomes. What does that mean? Don't have 5 measures when you want to know if they're underpressed. Pick a measure and find out if they're underpressed. Electronic health record with measurement-based care built in now becomes a way that you can, as the VA has already done, which is terrific, is a way to get data out of everyday routine care. Use social media to recruit, again, secondary analyses to generate hypotheses, web-based data acquisition, so on and so forth. You know a lot about these. I'll give you a couple examples. So simplify research outcomes. Why are we doing a ham 17 when a ham 6 does better? That's a simple question, right? This is not new. Heuristic has been talking about this for 10 years or maybe 15, I can't remember. But here's a recent study we did. We took the STAR-D data or the COMED data, and we said, let's do the ham 6. Here are the 6 items. Here are the domains. We did the IN6 with the same. We just pulled 6 out of this 30-item questionnaire, and then we asked the question, okay, how good are they? And how good are they? They're more sensitive to improvement. They're more sensitive to percent response and percent remission. Why? Why are they more sensitive? Because they're unidimensional, and they're measuring one thing, not 5 things. And indeed, if you look at the ham 17 B6 items, they account for about 75% of variance in the entire Hamilton. So if you want to do a Hamilton, don't do a 17-item Hamilton, do a 6-item Hamilton, or even better, maybe a PHQ, or even a shorter PHQ, etc. That's an example of just trying to make research a little bit simpler. Report clinically important information. I'll illustrate that in a minute. Webinars so the authors can talk to practitioners about what their findings really mean. AMC, synthesizing and publishing annual updates around various diseases that patients need to know about. You have Walter K's program here in anorexia, what's new in anorexia, ADHD, you have autism, you have lots of interesting things. Patients will buy this stuff. Trust me, I'm one that buys this stuff. Atrial Fibrillation, I can't stand it. And I think it's a very good role for the academic medical center. Okay. Example, I'm just going to give you a couple of examples of this. Here's the STAR-D findings. We found that, as you know, if you're in remission, you don't relapse as much as if you're not. But what's interesting about this is, who are these people who are relapsing on drugs? And what can we do about them? And can we identify them? Because those are the ones that we got to find and fix. And who are these that we don't have to worry about so much? We don't spend time on that, but that's a clinical question that matters a lot. Okay? That's an example. Here's another one that's a little complicated, but I'll make it simple for you. We did a post hoc analysis on STAR-D. We also did it on COMED. This is published in 2010. Dr. Cook is a statistician, and Lee Jacqueline and I did this article. What we did is we said, we don't want to just find out using an ROC curve whether we can predict outcome or not. What we want to do is we want to find people for whom outcome is predictably bad as early as possible so we can stop the treatment. That means you want to have a negative predictive value with a high specificity. And in addition, we are willing to have people go, you won't get better, you will get better, and we don't know. And if we don't know, it's fine. We'll leave it at we don't know. What I want to do is get rid of the people that really won't do well. So I want a high NPV. We set it at 0.75, the specificity. And we said anybody that has less than 25% chance of doing anything with a treatment. Okay. So we analyzed the data and we put in this metric here, which is how much change or lack thereof at week 2 from baseline did they have. Very small, modest, none at all. And then we calculated the negative predicted value for each of these entities, and then we fed in other elements, chronic or not, men or not. And if you can see the bold, so the bold here, no improvement in 2 weeks with chronic, with minimal improvement, or the men but not the women with very modest improvement, leading us to an overall NPV of 0.8 for a total of 403 patients. That's a meaningful proportion of the 2280 we started with, right? Because that's about a fifth, about 20%. A meaningful proportion of people could have avoided the rest of the treatment if we know the 2 baseline and 3 baseline features and their response at week 2. We could stop the study, stop the treatment, not the study. Okay. If you do it this way, it's the same sort of data. So there's a group that's non-responders, shown here. There's a group that's intermediate. There's a group that's responders. The intermediate means we don't know which way they're going to go, and we leave it. So this is just trying to analyze the data to answer a practical clinical question, which is, can I remove anybody from treatment at week 2 that's not going to do well enough with this treatment to go forward? Okay. Final illustration in this regard, and we'll get to close up. This is unpublished data from Stuart Reed, who's in Australia, and it comes from the iSpot study, and this is a functional anisotropy using DTI and a ratio of 3-term analysis versus the simulated portion, the simulated bundle. What's interesting here is this is a simple ratio, empirically found. The non-remitters are in red, the remitters are in green. Okay. If you use a ratio of 1, the probability of these people with 1 or greater responding or remitting in this case is extremely low. So this is to any one of 3 drugs. So is this potentially a biomarker for TRD? Or is it a method by which you could sort people who are going to take a whole different kind of treatment? The reason I'm emphasizing this is not the anatomy and not the brain imaging, but the notion that if you can isolate a meaningful proportion of people who won't do well early, and this is at baseline, this is no week 2, then you've actually got something that you can act on that says, that's actionable clinically, which I think is very, very important. So it's not just, is this statistically different? Is it clinically actionable? And that's, I think, where our science has got about it. A couple of comments on clinical care and clinical care, obviously, we have to train the next generation, and we have to document the competency and so on and so forth, and fill information gaps. And notice this in clinical care, this is a role and this is a role in clinical care. So it's a dual role. The clinical tasks are listed here. We're all very familiar with them. And how well do we do those tasks, and how do we train people to do those tasks and get them experience enough to do them is obviously what we're all about, but this is the knowledge gap that we confront. So this is what happens when the drug is on the market. We don't know who to treat it with, how one can use it, what the real ADs are, how to sequence it, et cetera, et cetera. Okay. So why are there gaps? There are gaps because I've already alluded to this in phase 2 and phase 3 study design, so we have limited populations and limited generalizability. And what can we do to actually fill the gaps? So possibilities, and these are just ideas to be thrown out and discussed. Registries can be very informative because we're treating large numbers of real patients in real practice, and they come with all kinds of comorbidity and all sorts of other things. But we're not very good at actually predicting who's going to get well and who's not going to get well, and they won't enter randomized trials, so we don't really know. We know kind of by looking and guessing. I think it's very easy to start registries to answer some of those questions, and you can tag on other things like biomarkers. This is a point-of-care clinical trial. This is a very simple idea. The idea is you don't know whether you should see a patient every 2 weeks or once a month to manage their schizophrenia. You randomize. And everything else is automatic. And you can do that in the VA very easily, and you can decide, is twice a month worth it or not? Worth it means, how many people have relapse or hospitalizations? Can you get away with 1 month, every other month, and so on? Very simple designs. And I won't go into all these other designs, but there are lots of really relatively simple to implement clinical designs that don't take a huge amount of money to do if you have a simplified outcome and clever questions. Other issues are in care delivery. Some of you are already doing a lot of teletherapy, web-based therapy, televisits, and I would even say that you can do teleconsultation to give CME at the same time. So a person in one part of California calls with the patient on the Skype. The consultant is here. They charge for that. They issue CME, and the patient is helped. Different ways of doing things. Telecommunication is CME. Okay. So conclusions, and maybe have a little discussion. I hope. I actually think that this is a great time to be in academic medicine because the times force change. You have to change. So we've got to innovate, we've got to come up with better interactions, and I think we really have to push learning by doing as opposed to learning by lecturing, because I don't think we learn by lecturing. I think we need to focus on outcomes, not steps to ensure guideline conformance. I think we need to change the incentives as well as the designs and methods for getting data. We need to create our ability to learn from our own practices. I always talk about that as a learning healthcare system that doesn't have to be just from the systems point of view. We need to revise how we deliver care to take care of the new technologies and the things that our trainees will be doing in practice. I saw an ad by Unum the other day. Unum is part of United Behavioral Health. It's a wonderful ad. I'm sitting there in Santa Fe, and it says, work when you want, work where you want. We pay when the patient has missed appointments. So I now can sign up and be a psychiatrist for anybody in the country, and they pay me when I'm on the Skype and won't pay me when I'm not on the Skype. Like, that's pretty good, right? It's not all that innovative, except it's very appealing to people who want to work under certain circumstances. We need to have our trainees be able to do that, and we have to be able to compete with what they're offering, because otherwise all our faculty will go over and do the sitting in Santa Fe. Pay for teaching up heuristic work. Heuristic supervision in real time, in the real clinic, I think is critical. Seeding innovations from independent sources, obviously administrative work is important. Revise how we deliver care, reduce silos, and so on.